Believe me, I'm feeling the hours that we've put in like you guys, but I appreciate you hanging in there for the last section of this Introduction to Economic Evaluation, which is cost-benefit analysis. And so we've been talking a lot about cost effectiveness and using that term, benefits. And I think it's safe to say now that these methods, they are two separate methods for doing economic evaluation. It's safe to say there's a lot of overlap now, so I'm going to address that in this talk. Okay, so one just subtle point to mention here is that we've talked about cost effectiveness analysis. I don't know if the term cost utility was raised, but that's when you're essentially working with QALYs as your outcome. And cost benefit analysis. These are three approaches to doing what we call a full economic evaluation. And so what makes it full? Well, there have to be both costs and consequences considered in the analysis. So we heard a little bit of this in Dr. Linus's talk about there being, the costs and the consequences. And there also has to be a comparison or a trade-off between two or more alternatives. That's what makes it a full economic evaluation. You might ask, well, what is a partial economic evaluation then? And this is where you would have a standalone cost analysis or a standalone efficacy or effectiveness analysis, or maybe just a cost outcome analysis. These are all useful tools, but if you really want to understand efficiency, which we've also a term we've heard throughout the day, economists tend to be very focused on what is efficient, right? Especially as part of the decision-making process. So for that, you really do need to have a full economic evaluation. So as far as cost-benefit analysis, traditionally, or maybe I should say historically, this was considered broader in scope than cost-effectiveness analysis. This has started to shift a little bit because now we know with CEA as well, we're interested in the societal reference case, the societal perspective, and the healthcare perspective. That brings a lot of overlap between the two methods, but traditionally CBA was, these methods tended to be a little bit more siloed, and so with cost effectiveness, you would do analyses like many that we've seen today where you want to understand what is the additional cost to achieve a unit of desired outcome. And in substance use, that could be a QALY, as we've seen today. How much does it cost in the experiment? How much more does it cost in the experimental condition to gain a QALY relative to the control condition? In the substance use world, this could also be asking how much does it cost to achieve one additional day of abstinence in an experimental, an intervention condition relative to control or treatment as usual. So that's a very nice summary metric. What is the cost to achieve this? But you do have to go on and ask, well, is that a good investment? I mean, is that something we're willing to pay? And with cost-benefit analysis, everything is in dollars, as I'll talk about a little bit more, and so it becomes a little bit easier to make those sort of decisions about what is worthwhile, what is a good return on investment. So with CBA, it's all about the societal perspective. So we're interested in, we want to maximize social welfare. This is really rooted in welfare economics or welfarism, and so it's all about the social planner maximizing the welfare of society. And so when we do the accounting of costs and consequences, and in this case, the consequences are the economic benefits, and I'll explain how we measure those in a couple of different ways. In this case, it's the social costs and social benefits that we're interested in. And doing this, again, we want to inform questions about what is efficient, what should we be doing with these limited resources, with our public dollars, if you will, and also gets us at, are these programs worthwhile? Something may be cost effective. We can still go on to ask, well, but is it worthwhile? Just because it's cost effective, it's not cost saving, as Dr. Linus mentioned. And so we have to come back to and think about addressing the worthwhile. So just a few comments on efficiency, because I know we've mentioned it a lot today, but if you pop open a basic economics textbook, what you're going to see is this graph that I'm going to put up in just a minute, which is showing you the trade-off, or showing you a comparison of marginal benefit and marginal cost. And so if marginal, really we're talking about the change in this case, the change in total cost, and comparing that to the change in total benefit. And when these things are equal, that's the efficient point. And so the viewpoint, what goes into calculating costs and benefits, or in this case, marginal cost and marginal benefit, depends on the perspective of your analysis. So emphasizing again that one of the very first steps you take in designing an economic evaluation is, well, from whose viewpoint am I going to be doing this? That's going to determine what is accounted for in your cost and benefit calculations. So let's do a simple example, and I'm just going to show you how the difference in perspective is going to also tell you something about different levels of efficiency. And this is a basic example thinking about expanding needle exchange programs in the state of Florida, which is something that's very near and dear. I'm pointing to a couple of the University of Miami students that are involved in what is just a pilot study in Miami of a needle exchange program, the first in the state. And so there's a lot of interest in expanding that, and so this is very much on our minds in Miami, so I thought it would be kind of a good example here. And so this is, again, a simple graphical illustration of how the pursuit of efficiency will change with perspective. So if you think about first doing an analysis, trying to understand costs and benefits from the perspective of, say, a private foundation. So this particular pilot program, needle exchange program in Miami, is funded only by private donations. The state is not involved at all. So if you're thinking about this from the private foundation's perspective and you're interested in the benefits to you want to be able to show that you're averting overdose. So think about what streams of costs and benefits associated with that would be relevant. So really, what are the costs? Well, the cost to operate this program. And the benefits could be things like accolades from reducing overdoses, access to more funders, and so on. And so in this case, where do marginal benefit and marginal cost meet? Well, right here at Q1. Right, so this is the efficient, from this private foundation's perspective, the efficient number of needle exchange programs to operate in Florida. Okay, I think that's what that says there. All right, so now transitioning to think about this from a broader perspective. So comparing the social versus the private marginal costs and benefits in this example. From the societal perspective, Q1, it turns out, is going to be too few needle exchange programs. Why? Well, let's go back to thinking about what would go into the marginal benefits and marginal costs in this case. And so on the cost side, it's not just the direct costs of running this program, right? There's also, these sort of programs have a lot of donated resources, like lots of volunteer effort, a lot of donated syringes and medical supplies, reduced property values perhaps, where the exchange program is located. That could bring down the property values in that neighborhood. And so that would be a cost. And so adding all of these things up means that your marginal cost or your marginal social cost is obviously going to be higher than your marginal private cost from the foundation's perspective. On the benefit side, it's not just reducing overdose, right? But it's also any additional medical costs that could be reduced from having this program. It's also reductions in skin infections, reduced HIV, HCV risk, maybe even broader things like positive impact on families, improved productivity, and so on. So once you add all of these things up, your marginal social benefit is also going to be higher. Next slide. So what does this look like in the graph? Okay, next one. There's the higher marginal social cost. Okay, next one. Should be, yeah, and the higher marginal social benefit. So you see here, go ahead and move to the next one, that the efficient quantity, what we would characterize as efficient here, is actually Q2, a higher number of needle exchange programs to fully account for the streams of social costs and benefits associated with this program. Okay, next slide. Okay, that's what that says. All right. And let's continue on. Okay, so Unlike CEA, the cost-benefit expresses, in getting to the results, we're expressing everything in dollars. So costs and consequences. Costs are obviously already in dollars, but consequences have to be translated into dollars. And so the results of a CBA are primarily a net social benefit. This is just simply subtracting the costs from the benefits, and if it's greater than zero, voila, you've shown that this program is cost beneficial, cost savings. There's different ways we can characterize that. That's your goal. Figure out if these programs have a net social benefit that's positive. You can also calculate a benefit cost ratio. So with cost effectiveness analysis, it's of course all about the incremental cost effectiveness ratio. With CBA, you can have a benefit cost ratio, but there are certain caveats associated with that, which I'll discuss in just a minute. Not surprisingly, if you think about, even in that previous example of the needle exchange, these streams of benefits that come from very disparate outcome domains, very disparate measures, how you translate those into dollars is one of the primary challenges of a cost-benefit analysis. Okay, next one. So the two key resources in doing these sort of analyses, if you want to turn to the literature, are these books that I have the image of here. The blue one is the Drummond et al. And so I'll be referring to some of the information in that textbook as well. The yellow one, I don't think anyone did show a picture, but we talked a lot about this one today, which is that this is the second panel, the findings from the second panel on cost effectiveness in health and medicine. And I mention them both because there is so much overlap now with this interest in the societal perspective. And so they're both great resources for understanding more details about the methods that we've talked about today. Next slide. This is a useful schematic from the Drummond book, and this sort of lays out, if you're approaching an economic evaluation, what you need to think about. And we've talked about the cost side here. Bruce talked a lot about this morning. And so the way the Drummond book organizes this is you think about four main areas of cost: the health sector, costs to other sectors like the criminal justice sector or education costs, patient and family costs, and then productivity losses. So these four bins, if you will, can characterize costs. They can also be used to characterize or to estimate benefits on the consequences side. Next slide, next button. Yeah, so this is what we're going to focus on now, is thinking about the consequences and how do we express those as economic benefits. So it can be about the health sector, or it can be about measuring the impact on health in dollar terms. Okay, next slide. This actually matches up. If you were to look at these, it might be hard to see on the slides, but if you open the books and look at the Drummond and the Newman second panel book, this is the impact inventory from the second panel on cost effectiveness. And it really, essentially, you can click the next slide and it'll, I think, circle, yeah. So there's a lot of the same things that you see in that Drummond et al. Schematic that's emphasized here as well, pertaining to cost effectiveness analysis. So it's just another illustration of how we're really broadening the perspective in both of these, in the cost effectiveness perspective as well. Okay, next slide. All right, so let's talk a little bit more about benefits. So there's really two approaches, again, sort of drawing on the textbooks in this field of estimating economic benefits. The first one, next slide, is willingness to pay, which, again, we've talked about a lot today. Willingness to pay is sort of the second thing you ask once you calculate a cost per QALY. You ask, okay, are we willing to pay that per QALY? Well, that's also relevant for benefits, and we can think about it not just in terms of QALY, but any impact on reducing mortality or reducing morbidity. How do we translate that to dollars? That's going to get us thinking about how we value life, and so that very much comes into a cost-benefit analysis. Next slide. The second approach is what I referenced just a minute ago, is thinking about consequences in terms of the impact in those four areas that are outlined in that schematic, right? This schematic here, health, sector impacts, so we would want to think about health services utilization and how an intervention might be changing that. Maybe we want to reduce certain types of health services, utilization of things like emergency department, right? So those things could be characterized as economic benefits, as well as the impact on other sectors, reducing patient and family time invested with having to pursue treatment, for example, could be translated into benefits, and productivity gains obviously could be translated into benefits. Okay, let's move forward. So let's first talk about the number one, which is the willingness to pay, and talk a little bit about how we value health and how we value life. So there's actually three approaches. Again, this is very much referring to sort of the textbook understanding of economic benefits. And so for valuing health and life, you have the human capital approach, what's called revealed preferences, and then number three, stated preferences. And that is actually willingness to pay, again, or sometimes called contingent valuation, which we've talked about, but we'll talk about it some more. Next slide. Okay, so the human capital approach, this won't be surprising. If you think about human capital, you're probably thinking about, okay, something to do with productivity or earnings, and that's exactly it. So we use someone's wages as essentially the prices of an hour of time, the value of an hour of time. And as far as the full benefits of maybe extending life, we can translate that into benefits by calculating the present value of future earnings. So I say there's a problem. I should ask, does anyone have a problem with that? We haven't talked about, wages are very accessible, so we love to use them for monetizing things, but there's obviously some issues with, does that accurately reflect someone's time? What about sort of racial differences in earnings, and what about people that are not in the workforce? Is their time worth zero? Clearly not. So we've got to think. We do a lot of talking about how to proxy for time that doesn't have maybe an explicit wage. And sometimes we use something like the minimum wage as a sort of a lower bound on valuing someone's time, but there's obviously some issues with that. Okay, but that's the human capital approach, earnings. Let's move on to the next one. So revealed preference, this is kind of an interesting area where you can actually look at some of the decisions or choices people make. It is related to wages, but thinking a little bit more about people accepting higher risk jobs for higher pay. And so this sort of is this understanding this trade-off between health and money. And these sort of, there's several analyses in this area that will estimate the value of a statistical life. And so here's a good example of that, kind of a simple example. But here suppose you're comparing two jobs, A and B, which are identical except that job A has a higher risk of death on the job than job B, but workers in job A earn $500 more per year. Well, just based on that, using what's called, I don't say it here, but it's called the Jones-Lee approach, you can get the implied value of a statistical life of $5 million. Why? I mean, this is also related to an expected value calculation, which Dr. Linus mentioned. And basically, workers in job B are willing to forego that $500 of extra money per year to avoid this 1 in 10,000 risk of death on the job. Okay, so we can translate that into value of statistical life. Move on to the next slide. There's another very well-known study in this area by Viscusi and Aldi, which did a comprehensive review and meta-analysis of several studies in this field that looked at wage risk trade-offs, that looked at some other protection activities that people engage in, like having a security alarm, and did sort of different ways of averaging out what is the value of a statistical life across all of these different studies that measured these sort of trade-offs. And what they came up with was a median VSL This is back in 2000, so we could inflate this if we wanted to, but of 6.7 million. And so this is not, I want to mention, the same thing as the value of a QALY, right? The QALY is this year of perfect health. And in this case, the value of a statistical life is useful for primarily for looking at marginal reductions in risk associated with, say, food safety policies, or the EPA uses this to look at how reacting to environmental disasters or things like that. Marginal reductions in the risk of death, and that is valued in terms of benefits using this value of a statistical life. Okay, let's move on to the third one, which is contingent valuation or stated preferences. And here we've talked a lot about willingness to pay for a QALY, and we have this sort of threshold of 100,000, used to be 50,000. It's not clear where this came from. Well, there are a lot of studies that ask about willingness to pay for outcomes, and that is considered when you are able to extract that sort of information, you can use that willingness to pay, that expressed willingness to pay by a community, by a population, as your measure of economic benefits. And these are much more popular in transportation, as I say here, and in environmental economic studies, and very exploratory, especially in healthcare, but especially in the substance use field. But I thought it would be, since I want us to be thinking about, go on to the next slide, please, the benefits. I thought it would be fun to just do this brief survey so you guys can tell all of us your willingness to pay for successful substance use treatment. And this is based on a pilot study that was conducted a few years ago by Gary Zarkin and Laura Dunlap and some of our colleagues at RTI. Some of you may be familiar with their work. And this was pretty novel because it was the first willingness to pay study asking people about what would you be willing to contribute to promote successful treatment, and ensure that people are getting successfully treated for substance use. And so they actually conducted surveys in two different areas, in New York, in Brooklyn actually, and in North Carolina. And they essentially camped out, as I recall from the study, camped out in front of malls and just sort of caught people as they were coming and going and got them to fill out this survey. And so they're asking, how much are you willing to pay for successful substance use treatment? And they're trying to also assess, are people willing to pay different amounts for men versus women, or for a co-ed program specifically versus a female-only program. So we're going to take a pause for a minute, and I'll read this survey. And what I'd like you to do is I can ask for volunteers to just shout out some numbers, and Jared is going to enter it into an Excel sheet, which we can then project up here, right? So the first one is asking about willingness to pay for all drug users. And the way these surveys are structured, they have to give enough information about the problem so people feel like they can answer it. They have to tell you, think about your income. The way these are structured are very specific because it's sometimes challenging for people to think about willingness to pay. So this is the way they did this particular survey. So it starts out saying drug abuse costs society a lot each year, not only in terms of money, but in high crime rates, lost jobs, and drug-related illnesses. In this community, North Carolina or New York, there are several thousand people who use cocaine, crack, or heroin. These people often commit crimes to support their habit, and many of them are unemployed because of their addiction. Drug abuse by pregnant women can be especially costly because these women may have infants who weigh less than normal and are much more likely to die or become sick. Drug abuse increases healthcare costs because intravenous drug users are at high risk of spreading AIDS and other diseases. Drug abuse treatment is one way to combat drug abuse. Successfully treating drug users will lower taxes by reducing crime and healthcare expenses related to drug abuse. Successful treatment of drug users will improve life in the community by lowering the crime rate so that people feel safer. Successful treatment of drug users will also increase employment. So then they're asked, suppose an existing drug abuse treatment program in this area, North Carolina or New York, is considering expanding its program. This expansion would allow the program to successfully treat 100 more drug users each year. So they ask about two numbers. They ask first about successfully treat 100, and then they ask about successfully treat 500 more drug users each year. What is the maximum amount that you would be willing to contribute to help pay for this expansion? As you answer this question, please consider the following. The expansion to the program will be paid for by contributions from area residents and cannot be started unless a minimum amount of money is raised from people like yourself. Think about your current income and what you would give up if you made a contribution. And so then you're supposed to circle the amount you would contribute. You can say, I will contribute nothing, I will contribute less than $5, and then you can specify, or you can select $5, $10, $15, all the way up to more than 500. And then you can also answer, I prefer not to answer. So think about that, if you will. The second survey is specific. So this is for a co-ed program, successfully treating 100 per year, successfully treating 500 per year. The second one is very similar, but it gives information more about female substance users and a lot of the issues that pregnant women that are using substances are dealing with. But again, they're asked, how much would you pay to treat 100 women successfully or 500 women successfully? And so if you want to think about that a little bit, or if you have an answer, yeah, so this is outlined here pretty well. So does anyone want to offer, let's do like 5 or 6 for each one of these columns. By the way, I ask this to my graduate students that look at me and they say, we don't have jobs, so how do you want us to answer this? Okay, we have 100. Okay, so let's start with the successfully treat co-ed anybody 100. And someone is saying, I'll pay $100. I'll contribute $100 towards this. Anyone else? Correct. So yes, so it's not per year. I mean, it's actually not specified, but the way it's presented is this is a one-time contribution to expand treatment to be able to do this. So you just think about it now. It's a one-time thing. 100. Another one for 100. 25. Dr. Shackman, 25. Do I hear 30? 30. 50. Another 50. 200. You are a bias sample. Anyone else? Okay, what about 500? So now you're going to contribute to this program. It's going to expand enough that 500 people will be successfully treated per year. None of you have asked me what successfully treated means. Does that mean they relapse in 30 days or 60 days? It's kind of daunting, but they don't really specify that either. So 500. 250. 50. 150. 150. 200. One more. 300. All right. So let's move over to women. And so the question here was, do people feel differently about women with substance use disorders? You can tell this was written a while ago because they say drug abuse, and we're not supposed to say that, now it's substance use disorders. So, but anyway, how about successfully treating 100 female substance users? 150. 75. 75. 100. 200. 2 more. Miami people, what do you say? Come on. 75. And 400. Okay. One more time. 500, successfully treating 500 women. 500. 200. 200 and 250. 150. I'll say 275, just to keep it moving. And 500, okay. All right, so somewhere on here we should be able to see what this means in terms of the means. Okay, so we've got, for successfully treating 100 substance users, we've got an average willingness to pay of about $80, $79. For successfully treating 500, it's $229, we're rounding up. For successfully treating 100 female substance users, 153, 154, and 296, thank you, for successfully treating 500. So this is sort of intuitively what we would expect, that people would be willing to pay more to successfully treat more, right? So this is sort of consistent in that sense. What did the study find out? So if you click on that other tab, this is the results. I did say this was a pilot study, but it just goes to show that the results don't always make sense. So here we've got, they found people were willing, different obviously in North Carolina versus New York. They were willing to pay 40 in North Carolina to successfully treat 100, and 32, 33 in New York. And curiously, a little bit less to treat more in North Carolina, and the same thing in New York. For women, they were willing to spend a little bit more to successfully treat 100, and in North Carolina, they said they would be willing to pay a little bit more to treat 500 successfully, and actually a little bit less in New York. So these are kind of all over the place, and that's one of the issues with willingness to pay is that there's a lot of inconsistencies, especially with a small survey, a small sample like this. It illustrates, if you were thinking about your willingness to pay, these are the benefits to you of this policy. So we could talk about a whole number of different things that we want to see happen, and what is our willingness to pay. And so that would then become, as I've said, our measure of benefits. And so let's see, what do I have here? Yeah, so there's a lot of inconsistencies. The elicitation method, like I said, you've got to be careful how you structure these surveys, because if you start out by saying, would you be willing to pay $50 for this, then you've got these biases that are introduced, right, starting point bias. And if you're just asking about one program, you're not doing the comparison thing, which is important for efficiency, right, and for understanding which alternatives you should be supporting. So these are just things to keep in mind. But in theory, this is supposed to be a good measure of the economic benefits of a program, a policy. Okay, let's continue on. But there's another way to do this, which is actually more common, especially in the substance use field. And it's sort of that number 2. If you think back to the schematic that I showed a little while ago, it's where you think about the impact to those 4 different areas: health services utilization, other sectors, patient and family time, and productivity gains. So these are things that many, many studies measure. And so the question is, how do you take something like, a criminal justice event, an arrest, or an act of robbery, and translate that into dollars? Well, it turns out we can do that. And so let's move on to the next the next slide. Oh, there it is, okay. So this just gives you, this is, I think, also sort of a useful quick reference of what are all the different areas that we're talking about with substance use. And so there are really 6 that are represented pretty well in the literature and in a lot of the surveys that are used for these outcome assessments in a trial of a substance use intervention. And so here you've got physical and mental health services, criminal activity and criminal justice system, substance use disorder treatment, social and community services, productivity, and quality of life. Okay? And so within each of these domains, there's a whole number of different measures that are asked, and you've got to figure out, we figure out, well, which ones can we actually monetize? And so some examples of assessment instruments that are used in this area, many of you may be very familiar with these, are the GAIN, the Global Appraisal of Individual Needs, the Non-Medical Services, the Econ Form 90, Addiction Severity Index, which is sort of going back a ways, and then the Phoenix Toolkit, which is actually one of the products coming out of NIDA's interest in data harmonization. And so they got all the experts together and said, let's try to come up with the whole list of measures that we want to encourage people to use when they're doing substance use disorder research. And so the Phoenix Toolkit actually has a number of potential economic outcomes in there. And so what is the approach? Well, you're taking units like an emergency department visit, as I said, committing a robbery, an outpatient visit, a DUI, a day in a homeless shelter, a day missed from work or school. These are units that are counts of things that we can then look to the literature and say, well, what's the dollar value of those? So we're thinking, again, we're talking about how do we translate changes and outcomes into economic benefits? Well, you want to look at reductions in visits, and then the value of those reductions. You want to look at fewer robberies and other offenses, and then the value of that reduction in crime, and so on. So let's move on to the next one. So we've actually, I mentioned we've done work in this area. This is something that needs to be updated. I don't want to say continuously, but every few years we need to be looking at how we're valuing these different things, because as more and more information becomes available, we can create better estimates. But basically, we did a study recently, it's in the Journal of Substance Abuse Treatment, where we decided to look at all of these different monetary conversion factors, which is a very fancy way of saying like unit cost or price weight. That means all the same thing, right? So we looked at the literature and tried to improve the estimates that we've been using to do these economic benefit studies, and now that are also relevant for cost effectiveness analysis, the societal reference case. Next. Some examples of the sources we looked at. So let me show you what's in this paper. For example, in the medical and behavioral health services realm, inpatient hospital day, that's $2,500 per day. On the high end, on the low end, a simple group therapy session, about $2 per patient. In substance use treatment, you've got detox is obviously going to be more expensive. It's usually inpatient versus a standard outpatient visit, $31 per visit on average. Infectious disease consequences, HIV lifetime cost, very expensive. So thinking about how, if an intervention is impacting, is reducing these things, start to think about how the dollars add up, right? Because these are our economic benefits. And for certain things, legal, reducing a murder, reducing things like aggravated assault, which I don't have the estimate here, but it's very expensive, like more than $200,000. Rape and sexual assault, more than $200,000 in societal cost per offense. So you reduce a few of those, and suddenly you've got hundreds of thousands of dollars in benefit attributable to, as long as you can attribute it to the intervention. The dollars can rack up very quickly. Let's move on to the next one. You can see some other examples from other domains, like productivity, a day missed from work, valued at $149. At the high end, a day missed from school or training, about $17. Social and community services, and then disability. Fetal alcohol syndrome is obviously very expensive. And then from the ASI, there are these measures of day experiencing a problem. And so one of my colleagues did a study many years, quite a few years ago now, but it's the only study that's tried to monetize these ASI, Addiction Severity Index variables. So that's from that. Okay, so how do we use these? Let's work through a very simple example given the time of day. And so this is, let's think about an intervention. So I just sort of was thinking about some work we were doing with the CTN on XBOT, and I said, well, what did that intervention look like? So imagine you're looking at an inpatient detoxification protocol followed by 6 months of standard outpatient treatment. Well, this doesn't have the medications in there, but anyway, let's assume you're evaluating this protocol for substance use disorder. And we know the daily cost of inpatient detoxification. So if they stay, it's $414 per day. So they stay 7 days plus 6 months of standard outpatient treatment, and they go to that 2 times per week. And we just, for simplicity, assume no one is dropping out and everybody's completing the full protocol. And so the average cost per patient in this case would be $4,510. That's the investment in treatment. And so then what are the benefits? Let's go on to the next slide. So these are all of the hypothetical outcomes that could be impacted, right? So you've got inpatient hospital days, and if you, I missed a detail, which is assume that there are 50 people that complete this protocol. And so you've invested $225,000 in treatment costs for that group. And then what does that buy you in terms of changes in these outcomes? So let's assume across those 50 people you had 25 fewer inpatient hospital days, and this is over, again, a hypothetical 2-year follow-up. You had 15 fewer emergency department visits, 1 fewer case of HIV, 1 fewer HCV, 35 fewer missed days at work, 5 fewer aggravated assaults, 5 fewer robberies, 10 fewer burglaries, 15 fewer days in foster care. And so add all of these things up with those monetary conversion factors, cost per unit, and what you get is 1.4, almost $1.5 million in benefits across those 50 people that you've invested in as far as treatment. Well, we have to compare that to cost, right? So you do the net economic benefit calculation, which is actually very simple. So you've got the benefits, 1.48 million minus the cost, 225. And what that gives you is a net economic benefit of $1.3 million. So that's something that policymakers would be very interested in seeing. And all of these methods, even cost effectiveness, what do the policymakers want? They want to give me the dollars and let me understand, if I should be funding that. And so this is really something that would be a big net benefit, a very convincing story in terms of supporting this sort of treatment protocol. You could also express this as a ratio, and so if you were just simply to divide benefits by costs, so the 1.48 million divided by 225, you would get $7 approximately in economic benefits generated per dollar invested in treatment. I'll talk a little bit more about that in just a minute in terms of we have to be a little bit careful with those ratios. Oh, okay, so we're already here, all right. And so this is what the results look like, so that just kind of shows you the formulas for what I just described verbally in terms of calculating the results, the net social benefits, and the benefit cost ratio. Moving on to the next one. So why is the ratio problematic? I don't know if maybe there's some intuition about this yet in thinking about certainly how we structure the cost effectiveness ratio when we factor in the societal perspective. I don't think we worked through anything that looked like that, but basically the cost effectiveness ratio, as you learned, is incremental cost divided by incremental effectiveness. If you want to expand beyond the healthcare sector perspective and bring in the societal costs, well, those are all being subtracted out of the numerator, right? So you've really got the costs minus the savings in those other areas that are part of the societal case divided by the effectiveness. And that makes sense for cost effectiveness analysis. For cost benefit or benefit cost, which is how we structure the ratio, it really depends on how you structure this. It doesn't make any difference for net benefits. It's always going to be the same, right? So you're going to have total benefit. So benefits minus costs gives you the net benefit, as you've seen. But what if we structure what if the benefits include, say, the health, the value of reduced morbidity or reduced mortality? So there's sort of a value of life piece plus all of those societal, the benefits that I described in the previous slide, so reductions in crime, reductions in unnecessary or unwanted health services utilization, reductions in foster care, and so on. If you structure it like that, where you add all of that up and then subtract the costs, you would get a net benefit of 6 and a benefit cost ratio dividing total benefits plus averted costs, dividing that by cost, total cost, you get $2 as your benefit cost ratio. If instead you structure it like the total benefits minus the total costs minus averted costs, and maybe you can see, I know it's kind of, at the end of the day, it may not be so obvious, but hopefully you can see how you can structure those equations differently. And what you would get is, instead of $2, you would get a benefit cost ratio of 2.5. And so I think, let's hit the buttons because I think there's some circles that come up. Yeah, so that just shows you how, you can go ahead and hit it again. You just have to be a little bit careful with the benefit cost ratio. Really, the core analyses tend to focus on the net benefits calculation as being sort of the main finding. Okay, let me just go through a quick summary. So the cost analysis, I don't think I mentioned this at the beginning, but this is the foundation, right, for all of these methods. So today you've learned about costs, that's our foundation, and then you've learned about cost effectiveness, cost benefit, and we've talked also, Dr. Murphy, a lot about QALYs, which is this huge important outcome for economic evaluation. The methods differ only in, because cost is in all of these things, right? Cost benefit, cost effectiveness. It's really the characterization of consequences that varies across these different approaches. Just to remind you, so cost effectiveness calculates the incremental cost per unit of outcome in one intervention relative to alternatives. The reference case includes healthcare and societal perspectives now very, very overtly. And CBA calculates the net economic benefit, comparing intervention costs to monetized clinical and economic outcomes. The societal TEA, as I've mentioned a few times now, overlaps considerably with CBA. Whether or not you can do them depends on how much data you have access to. I mean, we're still challenged in that regard. We do the analyses based on the data we have in hand. So sometimes that's limiting. We can't always look at the societal perspective, or we can't always calculate economic benefits. And so the option of having both approaches in our economic toolkit, for lack of a better description, is extremely useful, because both are telling us something about efficiency and guiding us and policymakers about what sort of programs we should be supporting, right, with public dollars. So even if you're not estimating the full societal costs, it's still useful to understand the cost to achieve some meaningful clinical outcome and have a discussion about, do we feel that's worth, are we willing to pay that for that clinical outcome? You're talking about reductions in outcomes that generate, so yes, it is saving money. It's not the point, as Dr. Linus said, though, to save a lot of money. You want to use those resources, but if you're comparing different alternatives, it's nice to know, especially if you're looking at this broad societal impact, how many dollars of benefit, how many dollars of savings are you actually generating by these different interventions. That's going to tell you a lot about, there's the is it efficient question, and then there's the, well, is it worthwhile? And so that's sort of understanding those sort of dollars of benefit that are generated. I mean, as we've probably pointed out a few times today, the terms are used interchangeably, which is why we hope it's interesting or informative to understand a little bit about the different methods, because they are really, supposed to be different. They all answer an efficiency question, but yeah, so it's cost effective but now there is this overlap, which makes it a little bit more complicated. But cost effective traditionally is telling you what is the additional cost to achieve this unit of outcome that's important for this intervention or this program. Cost benefit is telling you what is the broader impact, what are all of the benefits that are generated to society from investing in this intervention or this policy or this program. And so you translate, as Bruce said, everything into sort of this net present value. How convincing is that to policymakers? I mean, maybe not always so much, because I think Bruce said it's sort of the short-term impacts that are important, which is why sometimes preventive interventions get a little bit of the short end of the stick, because those sort of things do take years to fully reap the benefits. But anyway, it's important. We do understand that this is going to be triggering a stream of costs and benefits, and so you have to try to capture those as best you can. That's where the modeling, actually, that Dr. Linus talked about can be helpful in understanding those long-term projections with a little bit more rigor. All right. Thank you.